We're going to be talking about MATs, medication-assisted treatment, also known as medication for opioid use disorder. This is components of a successful practice, a team-based approach. We have nothing to disclose. So today's objectives are to describe the importance of using the team-based approach, to name the team members recommended for an office-based buprenorphine program, to describe the roles and responsibilities of every team member, address how your administration can support building a team, and recognize how the information provided may assist you in your clinical setting. So first off, using a team approach can help leverage resources. So we're going to talk about a note on treatment teams. There's the integrated treatment approach with multiple service providers working together. The screen, Rana, is, I can't quite read everything because of where the box is. Thank you. Is a research-proven model of treatment for people with serious mental illness and co-occurring substance use disorders. And this approach is considered the gold standard by nearly all of our regulating and research bodies. Integrated treatment allows clients to receive combined treatment for their mental illness in the same setting as they receive their treatment for substance use disorders and their other psychosocial needs from one treatment team, and this team meets regularly to coordinate their care and convey a consistent message about treatment and recovery. So it really helps avoid the fragmented care that can often happen when we have multiple sites involved. There's a difference between multidisciplinary and interdisciplinary, where multidisciplinary means that there's several disciplines doing the separate pieces, but again, they might not be necessarily working together. And interdisciplinary is when they each bring their perspectives and idea to the same table, and then that team formulates a treatment plan and moves forward implementing it together. So what are treatment team concepts? The first is that recovery is more than symptom remission and stabilization, and it actually involves developing new meaning and purpose in one's life. And so it's really a whole life perspective. The second concept is that of including all the people who work with the patient and the patient themselves in the planning process is crucial for success. So in other words, we're not just directing the patient, but the patient is also part of the development of the process. Next, if the patient does not have ownership of the treatment plan, then there's less likelihood they'll do the work directed by the plan and get better. So that goes along with the second concept. And also an infrastructure must be in place to promote team cohesion and allow the team to focus on clinical work. So there really needs to be that structure, and that's where administration certainly is crucial in terms of understanding this process and supporting it as well. And there's also an expectation that treatment teams use the treatment plan that is developed as the fundamental foundation for all the encounters and interventions that happen along the way, so that you have a solid core moving forward, and this also helps to avoid that fragmentation of care. So what are components of a successful team? So we're going to talk about these that are listed, including the program manager, recovery coach, therapist, pharmacist, the nurse practitioner, PA, physician, all members of the team. The team structure, so who is on the team? The core team includes the client and his or her primary treating providers. The extended team beyond that core include service providers who work with them less frequently, possibly at other agencies, or are involved in the client's care. So this could include concerned significant others. And what is the structure of this team? So the team must have a team leader or manager, and that person's responsible for the treatment plan and for the team as a whole. So that there's definitely a focal point, a guide, and this is often the primary person who's working with the client. And the structure must have a coordinator or recovery coach who's responsible for organizing the team meetings, communication, making sure that all documents are in place, information is being tracked accordingly, and that it's being recorded in the treatment plan. So you have really the responsible person for the team lead, again, probably closest contact with client, and then a coordinator, recovery coach who's really making sure that all the I's are dotted, T's are crossed, and things are in place. And then it must have flexible yet defined roles for all the other team members, so that each person knows their scope, what their role is on the team, and that also that there can be some cross coverage so that they can help fill other roles as needed. Okay, so now we're going to break down each of those team members. So who's the team lead or program manager? This can be an MD, RN, PA, NP, or an independently licensed therapist. But whoever it is should be a consistent point of contact for the patients. This person is going to coordinate the communication between team members and between the team and the patient. So again, really serves as that central figure. And they can also have some patient care functions, again, according to what their scope is. This person conducts the support or education groups. And in this capacity, this is where nurses have most frequently been utilized and studied. And we'll talk about that a little bit more later on. Okay, and then the next member is the recovery coach or engagement specialist. These can be nurses, community health workers, medical assistants, peer support specialists. This does require training to step into the role, so the person needs to be prepared for what the role requires and expectations of the role. And this helps expand services to the patient in order to help them engage more with services they may need. So administrative duties included in this particular role include perhaps if there's prior authorizations needed, checking the PMP, for instance, to be able to help with the efficiency of the visit or the refill. They will be able to be designated to the provider as to be able to see the PMP, the proxy, maintaining buprenorphine logs. So in cases, as again we'll see later, where there's a team-based approach to the actual prescription medication, they'll help maintain the record there. What clinical duties, so those are the administrative. Clinical duties can span from taking vital signs, triaging the patients, performing urine drug screens, performing pill counts, possibly if there's a callback or a requested that the patient returns with their pills, and administering rating scales. So again, this might be prior to a visit or between visits to assess these clinical points that are essential to providing good care. And then screening for co-occurring disorders. So oftentimes having that in place on a consistent basis helps avoid this falling through the cracks if, say, just the provider's meeting with the patient may not have that on their radar for that particular day. This will be part of the whole team approach to ensure it gets done. And then for patient education, this is another category where they can talk with the patients about the basics of buprenorphine, make sure they understand the treatment they're on, what the program expectations and requirements are. Reviewing harm reduction is essential at the beginning and at every visit, I would say, to have a consistent message there. And they can pull in other team members if needed. So certainly if they're being spread too thin or on a particular day, this would be an example of like getting trained for that cross coverage to be able to help out. And with experience, they could facilitate or co-facilitate groups, educational groups such as overdose prevention or relapse prevention. And then they also are providing psychosocial support. So they may be checking in with patients, say more frequently than, again, if a provider doing this solo could do so, calling, checking in with them, offering that kind of support that especially early on in recovery is really important. Making necessary referrals, and again, checking in. So referrals could be made by anyone on the team. Some referrals would be perhaps to groups such as AA, NA, or Smart Recovery. I would say that it's Well, I guess we talk about groups in other talks. I'm not gonna get off track here. Stay to the course. Let's stay to the presentation. Referrals to traditional healers, if that's something that the patient identifies with and would benefit from. Therefore, inpatient treatment programs, residential programs, these oftentimes require a bit of coordinating, and so helping with those referrals is a very important. Crisis line phone numbers, so making sure that patients have access to those, and also providing information and referrals to harm reduction sites, and those would be, for instance, needle exchange programs or sites with overdose prevention programs and medication. And then referrals for HIV, hepatitis testing and treatment services, if that's not located at your site. And if it is located at your site, then that person might also help link you to care right there. Referrals to emergency food resources, and also to housing and utility. Referrals to employment and education resources, and then psychiatric and medical treatment, again, if not provided on site, that they could help link to off-site treatment, and if it is on site, help coordinating it within your clinic. So lots of referrals that can help our patients. Okay, so now we'll move on to talking about the role of the therapist. This person has some degree of psychotherapy. There's some degree of psychotherapy required for all patients on buprenorphine. So we know that we try to get patients started on medication as soon as possible. And after that, or along with that initiation, if possible, getting them in for therapy will expand their chances of meeting their recovery goals. So these include cognitive behavioral therapy, relapse prevention, motivational interviewing, contingency management, and 12-step facilitation. So they can utilize you can utilize your in-house behavioral health team if you have those resources available, but you can also refer out for those services. And then I think that in some settings where it's difficult, if there's not a therapy site where the patient can easily access it on a regular basis, incorporating MI, of course, into the provider visits. Some of these resources can be integrated with the medical visit as well. The pharmacist is key to naloxone distribution, so for prevention of overdoses. And naloxone distribution is key in terms of helping both our patients prevent overdose in them, but also we often find that they're using it on people that they either know or don't know in some cases. So from a public health standpoint, it's key. The pharmacist can also serve a role in terms of patient education. We find that they get a lot of information from the pharmacist. They might be the first responder and also involved in community education. Pharmacists can also help educate providers on chronic pain management, help with identifying high-risk patients. So I know that our pharmacist helps a lot in terms of identifying patients who may have increased their risk behavior, and we may not necessarily be seeing them in clinic as regularly, and so we be able to see them more frequently, so that communication is key. And then pharmacists also assist with distribution, co-prescription of naloxone. Do you want to give this slide? So, and then our nurse practitioners and physician assistants play a central role. The CARA Act passed in 2016 greatly expanded access to buprenorphine because now PAs and NPs can prescribe. They can also administer and manage and prescribe naltrexone and naloxone as well. They work very closely with physicians and certainly on their own as well. in some sites. How about the physician? So I think physical exam goes with both the PAs, NPs, and physician. And we are also all assessing the appropriateness for treatment in our medical visits, providing the buprenorphine prescriptions. We can help provide training and education to the rest of our team. And this is a summary of who should be trained in the office staff for different procedures, different things that have to happen in order to make for a cohesive, successful program. So I'm not going to read each one of these, but you can kind of look through the list. So it's spanning from prior authorizations down to just basic understanding, addressing staff concerns, the PMP program, and then you can see on the right who should be trained for each of these roles. So for instance, in our office, the medical assistants may be the main people who are helping process prior authorizations. Occasionally the nurses will as well. All staff should be trained in basic understanding of addiction and in handling those challenging behaviors that can sometimes arise and setting appropriate boundaries. And also all staff should be trained in drafting and participate in drafting behavior contract and working with others who have concerns about patient behavior. So now we're going to talk about the Massachusetts Collaborative Care Model, which is a really neat model. And you can see in the figure on the bottom kind of a summary of it, but I think the next points kind of go through it piece by piece. Yeah. So this is a team-based approach that has been in the literature from Massachusetts. It increased the waivered physicians by 375% in 3 years. So one part of its effort was significant increased training. And then it also markedly increased patients on medication for their opioid use disorder, and notably, especially in minority populations. So nurse care managers were central to this process. The actual structure of it was on a team you'd have one nurse care manager, one MA, and that team would carry 125 patients on MAT. It was found to be financially viable and a sustainable program. And I think that what's showing on that figure there, it's just nice because it shows kind of the overlap of who is involved with that one patient there in the middle, just really providing support and making for a successful program. So ranging from the peer supports, medical support, other specialty providers, care coordinator, including friends, other people. So you can kind of think back to talking about the team-based approach. There's that core team and then the extended team, and this is similar to that. So what did they do? In order to, and again, this is just expanding access in order to get people into treatment sooner and have more treatment available than what would typically be available if a patient was coming in and seeing a provider just one-on-one for their treatment. So the initial screening assessment would be done by the nurse care manager. The chart would be reviewed by the office-based, the outpatient team, and then the chart would be reviewed, physical exam done, the opioid use disorder diagnosis made, and then the decision to start medication be made by the doctor. The prescription would be generated by the nurse care manager and signed by the doctor, patient fill at the pharmacy, and then the induction onto the medication would be assessed by the nurse care manager, given the education the patients need on the medication. And that titration and support would also, during the induction period, the titration of dose would be also conducted by the nurse care manager with the MD as backup. Same for the stabilization period and same for the maintenance. So it really provided a structurally sound method of ensuring that more patients were able to get care with the nurse care manager as lead, MA there in that core team, and the doc as backup follow-up, and the necessary points of signing prescription, making diagnosis. So this also describes kind of more in detail what those initial screening assessments in the Massachusetts model included. So again, the medical, different pieces of the history, patient education, the specifics on patient education about the buprenorphine, the lab testing that they do, pregnancy testing, infectious disease, the drug screening. And then there's farther down the list, the patient buprenorphine induction process and monitoring using that COWS scale. This explains how they use that at every induction and provide instruction on how to take it and how to assess for side effects. And then they would continuously work with the patients in order to provide support, ongoing medication, and again, titrate the medication as needed to get to the appropriate effective dose. So the importance of training. So the buprenorphine waiver training was key again to this process. There was addictions and buprenorphine 101 training for all staff. So again, going back to the importance of that PAN education for the site. Also talking about how to work with individuals with substance use disorder. I think addressing things such as stigma in this population, all of that as part of their general education. And then they offered ongoing trainings, shadowing opportunities, and clinical support. And then having the backup via telehealth or email. The policy and procedure manual can be adapted or modified for different sites. It's important to have billing support as part of the training. And then this is going through the details of training for providing office-based opioid treatment. Again, I'm not going to read through all of this, but you can see the details that they went through in terms of prescription, education, issues of confidentiality, and managing potential issues that could arise with patients, treatment agreements, managing possible diversion, etc. So the roles for clinic administrators for successful MAT implementation, I'll try to wrap it up in the next couple minutes because I know we have a case. The administration needs to support the clinical team, allow for regular meetings. There needs to be the space and time for that. Ensure adequate coverage if the team is meeting. And then they would also need to ensure appropriate staffing. So again, going back to that model, for patient care, allow time for the trainings and for continuing education, creating clinic policies or guidelines in conjunction with the team to make sure it's appropriate for care. And what can you do right now? Be an advocate for your patients, as I know all of you are, continuing to advocate and continuing to help create an accepting and patient-centered environment. Your work within the community and just being a figure that people look to and respect, that helps a lot when you're combating stigma, for it to then reverberate throughout your community. You can work with tribal, state, or national leadership on policies that will help benefit the communities, such as funding for treatment, drug take-back programs, education for community members, youth engagement, again, naloxone distribution programs. And that is all. I think